I think there's exciting things, and is the approach now that we have neoadjuvant chemoimmunotherapy. There is a gap on neoadjuvant therapy for patients with target mutations. Now, approximately 52% of patients with adenocarcinoma of the lung have a target mutation. So we talk about the need of developing therapies in the neoadjuvant setting before surgery, but we are target focused. So that's something that's very exciting to me. I think moving targeted therapies in the neoadjuvant setting, we allow for objective response, lower surgical times, less complications, more minimal invasive surgeries, and it also brings the importance of multidisciplinary teams, because now it's not like the surgeon does their job, the medical oncology does their job, but we all come together. Another area I think that's also very interesting is in spaces in which we have multiple lines of therapy, right? There's an agent that is approved for first line, and in some cases, the only agent. Now, more and more, we have 3 or 4 agents in first line. So we talk about patient selection and how to tailor each agent to the patient's needs, taking into account the benefits and risks of the agent, the financial toxicity, the access to the drug. So that was very important, the gaps, because when there's a lot of selections, how can we have guidance to doctors, not only in the United States, but globally? And finally, another area that I think was a lot of very interesting is disease after first line progression. Uh, when we're trying to understand resistant mechanisms to these target mutations beyond chemotherapy. So there is a lot of research and a lot of interest and a big gap of what happens after targeted therapy before chemotherapy in the metastatic settings. Most is to standardize treatment. When we don't have a standardized treatment, when there's gaps in care, allows for difference in treatment and for disparities. Disparities in which biases or lack of access or anything we influence the decisions. Furthermore, I think as a thoracic oncologist, I only see lung cancer, and that's a privilege. 80% of patients are seen in the community in which my colleagues had to treat breast cancer, anemia, leukemia, multiple myeloma. So providing consensus and guidance is helping the community as a whole, because if there is no guidance or information, anything is possible, and some of the options may not be the best options for patients. So we hope to provide guidance. Also, patient education is very important. So when we have consensus, the patients can have the information about what options are there. So there is many benefits from that. And the last benefit of the consensus is, where is the most pressing area of research right now? Where we also focus our energy to advance that area where there's a large gap, like lectomeningeal disease, that has a very poor prognosis. So if we have a consensus and we target the areas where the gaps and the needs are larger, then we all can focus our energy improving those outcomes.